Hello and greetings from a somewhat very cold Nairobi here in Kenya. My name is Liz Tonjira and welcome to the third edition of our media webinar series where we disseminate pertinent and key issues that we've been working on to our very critical stakeholders, the media. Today's session will focus on the key research studies that we've been doing, and the agenda looks like this. We'll be having opening remarks from our group CEO, Dr. Githinji Gitahi, followed by the Vice Chancellor of Amref International University, Professor Joachim Osur, who will be taking us through the study on COVID-19 Vaccine Hesitancy Studies, a case for community health volunteers and youth in Kenya, followed by Brenda Mubita, a program officer from Amref in Zambia, who will be sharing with us insights on assessing the impact of the COVID-19 pandemic and response on reproductive, maternal, child, and adolescent health service provision in Kenya, Uganda, and Zambia. Thereafter, we'll have Dr. Tony Kipsandui, a program manager in RMNCAH from Amref in Uganda, who will be presenting us the evidence on the effects of COVID-19 pandemic on FGMC and child, early, and forced marriages, the case of Kenya, Uganda, Ethiopia, and Senegal. Thereafter, we'll have Dr. Tamari Eshel, Director and FGMC Center of Excellence, who will be taking us through a multi-country situation assessment of community health workers' preparedness to support health system response to prevention and management of COVID-19 and associated gender-based violence. Thereafter, we'll have Martin Mushangi, Program Director, WASH and NTDs in Kenya, who will present us a study on the performance and utilization of hand washing stations deployed in response to COVID-19 in Kenya. We'll then have Dr. Shifra Kuria, a Regional Program Manager, RMNCAH and Nutrition, who will be sharing us insights on the equity in COVID-19 mitigation and policy responses, Kenya, Uganda case studies. And last, but certainly not the least, we'll have Dr. Jessica Nsugwa, the Commissioner, Department of Reproductive and Child Health at the Ministry of Health in Uganda, giving us insights on the role of research and development in informing government policies. Thereafter, we've set aside a full half hour for any questions, clarifications, additional information that you may be seeking out of this key studies that will be presented in a Q&A session, and we'll close thereafter. We have interpretation services for this webinar. If you check your right-hand side, on the Zoom. If you're from French speaking, please click on the channel that you'd like, either for English or from English or French, please do so. Without further ado, I will now open and present Dr. Githinji Gitahi for the opening remarks. Please remember to keep your questions coming in on the Q&A segment of the Zoom platform. Thank you very much. Over to you, Dr. Githinji.
Thank you, Liz, and thank you, colleagues. I am really excited. I see there are quite a number of people joining, which also speaks to the interest that is there within all of us to ensure we understand research and development and its role in health development, both regional, local, and global health. So this is really a good show. I think I'm seeing Liz almost 77 people, if I'm not wrong. Is that what I'm seeing, or 70-something people? So that is really, really encouraging. So wherever you are from, whether you're from in a country in the continent of Africa or you're from any other part of the world, feel welcome and feel free to have open conversations. What we are talking about is generally, and what I would like to leave on the table here is the role of research and development. Amref Health Africa, of course, has been working in Africa for 64 years, and we have been pivotal in a lot of the research areas in community health, development, maternal and child health, infectious diseases. We've done a lot of work in the past on diseases like Hydatid disease and others, and also have participated in health system strengthening through our implementation research, because research is not always molecular research. It's also a lot of implementation research. And I think what you'll see from colleagues today is largely around implementation research. Now, research and development is critical to health and development itself and to wealth and the socioeconomic development of countries. Right now, Africa is in a crisis on vaccine equity because there is no research and development for vaccines. And therefore, we have to wait for those who are able to invest in research and development and then discover the molecules that we use or the antigens that we use for vaccines. And then we have to rely on them to give us the licenses for us to probably, if able to, manufacture in the continent. So it's not always easy. And more recently, you've seen the clamor for more vaccines in Africa. And you've seen also for calls by India and South Africa requesting for the World Trade Organization to suspend intellectual property so that Africa and Asia largely can access licenses to manufacture vaccines locally. The long-term solution is for us to develop capacity for research and development on the continent continuously and invest in it, so that when we invest in it, the intellectual property is ours, and therefore we are also guided by the needs of the continent in development of whatever we need to do. There has been a concern, of course, that even research that's done across the continent is funded largely by the Global North and therefore is led by a Global North agenda, and Africa needs to put money for its research. Organizations like Amref, governments need to put money on the table so that we can develop our research locally and use it for our needs, so that our research agenda is driven by our questions, our problem statements. So this is really critical. And that's why Amref has decided to be doing this series of sharing his own research. Not that we are perfect at it, but we think it's important for us to continuously work with the further state and policymakers and others to understand what are the needs and how we can continuously develop this area. So as I try to open up this conversation, I want to share two stories. One story is in 1831, the year 1831, and the gentleman is Charles Darwin. And Charles Darwin was invited by the Queen's government to go on an expedition. Many of you who been, if you've read the history of colonization, not only of Africa, but also of South America and other, the Americas generally, and India. The story is told that the UK government, the British government, sometimes had actually more researchers and more scientists on the expedition ship than soldiers. And the reason for that is because the expeditions were for wealth. They were for actually finding out new horizons for wealth. That's what they were for. The story of Sir Edwin Chadwick, who was concerned with the constant outbreaks of infectious diseases, not least typhus. And because of that, Sir Edwin Chadwick developed what was called the Report on the Sanitary Condition of the Laboring Poor, basically indicating that the access to clean water and sanitation was necessary for the health and wealth of the country. And it was very controversial, but that is actually what saved the UK from disease. So the health we see with the UK people today, and largely Europe and developed countries, which is related to the development and investment in water and sanitation, came from the basic research of Chadwick, who was not even a scientist. He was a social reformer, a lawyer. So research is critical. And this is why we hope that for Amref, as we do our research, we hope that we don't only do research for the sake of it, that we don't only record and keep the reports, that we share with you, that also what are our policy recommendations for us to be able to move forward. So this is what we do. We want to look at policy to practice, that to and for us to change for Africa, and to look at what research, either implementation research or otherwise, can lead us to achieving lasting health change for the African continent. Thank you very much, and back to you, Liz.
Wow, thank you so much, Dr. Gefenji, for those insights into our work and the intersection between our work and research and development. Quite exciting for the coming years and sort of the output that we'll have on top of this. Without further ado, I want to introduce Professor Joachim Osur, who'll be taking us through the COVID-19 Vaccine Hesitancy Study. We've had a lot about vaccine hesitancy, and now we are happy that we do have some insights, numbers, figures around this on two demographics, community health workers and the youth in Kenya. Over to you, Professor Joachim. Thank you.
Thank you. Yes, I want to start by saying that I hope you can see my slide.
Yes, we can.
Thank you. I want to start by saying that right now, Africa is lamenting a lot about lack of vaccines. I want to say that even if vaccines were made available today, not all Africans will accept it. And you are aware that South Sudan and DR Congo made their vaccines, they were going to expire, and they gave them out to be used in other countries. And at the same time, Malawi had its vaccines expiring, and so they banned them. I think that has been in the news. And so when we make vaccines available, it's not that everyone will accept them. And the problem that we have is actually vaccine hesitancy. Vaccine hesitancy is the refusal or the delay in accepting to be vaccinated. Now, there are many reasons why that happens. We know that in the control of this pandemic, vaccine hesitancy is the one thing that is going to delay our control of the pandemic, and especially in Africa, where the hesitancy seems to be higher than in other places. We went out to do our studies to find out why there is vaccine hesitancy. And so the short presentation I'm going to make, I hope now it stays, is really some quick results on what we found out about vaccine hesitancy.
Thank you so much for such amazing insights into the youth, which form such a huge demographic in Africa, the community health workers who, since the pandemic, have been at the front line advocating and educating different communities on how they can protect themselves. These insights are really, truly eye-opening in terms of seeing the numbers in terms of vaccine hesitancy in Kenya. Next up, we're going to have a presentation from Brenda Mubita, Program Officer in Amref, Zambia. Brenda?
Thank you. Oops. Good afternoon, everyone. I don't know whether you are able to see my screen.
Yes, we are. Thank you, Brenda.
Yes. So I'm going to present on, I'm going to present on the research which was done sometime last year, around November, December. And this was a research which was done in Kenya, Uganda, and Zambia. So we're trying to assess the impact of COVID-19 pandemic. Let me just see. Yeah, the effect of COVID-19 pandemic and response on the reproductive, maternal, child, adolescent, and neonatal health service provision in Kenya, Uganda, and Zambia. Oops. Okay, please bear with me. I'm trying to make sure that I'm sharing nicely. Okay. Just bear with me. I'm just trying to ensure that you are seeing my screen properly. So I want to share a bit of background information on the research which was conducted in Uganda, Zambia, and Kenya. So the COVID-19 pandemic continues to pose challenges to the health system, especially in the African countries, those that are facing the second and third waves of this COVID-19. The pandemic, the pandemic and the mitigation measures are further complicating the already struggling reproductive, maternal, child, and adolescent health services, especially in the sub-Saharan Africa. Of course, you know that every pandemic always causes a challenge in the health system. So this research is focusing on the impact that is this current pandemic is causing on the reproductive, maternal, neonatal, and child health and adolescent services. So the disruption threatens realization of rights related to access to quality of these health services. The study assessed the impact of the COVID-19 pandemic and the associated responses on the provision of the access to and utilization of reproductive, maternal, neonatal, child, and health services. And we sought to document knowledge and perception of the health-related services in the Kenya, Uganda, and Zambia. So what did we find in this? Of course, as I've already mentioned, we're trying to assess and see if there was any impact that is this COVID-19 pandemic was posing on the reproductive, neonatal, child, and adolescent health services. So we found that the utilization of these services dropped due to fear of infection and movement restrictions, transport challenges, and difficulties in meeting the costs and inadequate information on the COVID-19. Of course, this COVID-19 was first pronounced in 2020, especially here in Zambia, around March. So most of the people did not have adequate information. Yes, and most of the people thought that if they could go to the health facilities, they could contract the COVID-19. So the other finding that we found was that the low provision of these services due to discontinuation of outreach services and unavailability of drugs, vaccines, medicines, and inadequate infrastructure, and also the burnout for health providers. You agree with me that when this COVID-19 was pronounced in all these countries, some of the infrastructure which was meant for the RAMCAN services were redirected for usage for COVID-19 patients. And by that time, we did not have any vaccines available. And the healthcare providers were overwhelmed to respond to this COVID-19. So we found that even the healthcare providers themselves did not even have adequate information on how to handle this pandemic. So there was a lot of burnout from the interviews that we had with the service providers. And also the other key finding which was found was that there was limited inclusivity in the development of laws and policies, many which were developed at national levels. There were a lot of policies and laws which were made to respond to this COVID-19, some of which were the stay-home policies, the lockdown policies, and you found that most of the people that were on the ground, the service providers, the healthcare providers on the provincial district levels were not included in coming up with those laws. So meaning that these people were not like contacted or even consulted on these laws. And even the dissemination itself was like, it was just disseminated from the national level and people just had to follow what was formulated at the national level. Yes. So from the research that was made, there were some recommendations which were done. Of course, when you look at the service provision, I was talking about the dropping of service, the services at at the provincial, district, and also facility levels. I think you've seen that there's a graph which is showing in red. It's skilled beds in 2019 and the skilled beds in 2020. So you have seen that there was a drop at some point. In fact, almost at all times, there was a drop of the skilled beds. And this is the case of Ndola or in Zambia, where you find that in 2019, when we did not have COVID-19, quite a number of people came to deliver at the health facilities and they were attended to by skilled birth attendants. In 2020, when there was COVID-19, we've seen that there was a drop in the skilled birth attendants, mostly because some of the skilled birth attendants, which were supposed to attend to these mothers, were redirected to go and attend to the COVID-19 patients. And the other thing is some patients, some clients could not come to access these services due to the reasons which we have already highlighted. Of course, we came up with some recommendations. So some of the recommendations that we made were that one of them is that the ministries of health is supposed to sensitize the communities on the available services and how to access them through community health workers and mass media. Of course, I already alluded to the fact that some people thought that the stay-home messages, the lockdown and everything else stopped the mothers and these youths, the adolescents, even to come and access these services. So hence the need for the ministries even to sensitize the communities to ensure that they know that these services are still being provided despite the presence of this pandemic. The other recommendation which we made was that governments should provide prioritize comprehensive support to healthcare workers. What are we trying to talk about? We're talking about the provision of protective personal clothing, equipment to provide them, and also psychosocial support, provide supplies and medicines. Of course, I mentioned that during this COVID-19 pandemic, even the medicines themselves were not as available as the pre-COVID era. So I think that the government should provide also these medicines, even for these RAM clients. So the regular updates also and provide accurate information on COVID-19. So what we found on the ground was that even these mothers that were coming to access the services did not have adequate information on this COVID-19, how it comes about and how to protect themselves from the COVID-19. So we're saying that it's important for the government also to provide this information for the clients as well as for the healthcare providers. The other recommendation was that the public health departments to provide community-based services such as outreach, because we also mentioned that during this COVID-19 pandemic, the outreach services were stopped. Meaning that, of course, you saw that there was a drop in the service utilization because of this stoppage of the outreach services. So we're saying that the public health departments will provide continued community-based outreach by using of these community health workers while observing the COVID-19 prevention measures. Because much as we have this pandemic, we appreciate and we know that we need to protect these mothers from dying from these diseases. The other recommendation that we made was that COVID task forces to include health providers and the community in the development and dissemination of health-related pandemic controls. Yes, of course, we've seen that the clients, the healthcare providers did not have adequate information. Hence the need for this task force to ensure that the health providers and the community are involved in the dissemination of these messages. So on the right, you can see that there are some quotes which we got from the clients. The clients complained that during the COVID-19 pandemic, the messages or even the information that was given to them when they came to access these services were brief. Unlike in the past when they could spend all the time educating them on this information, education, and communication on maternal related information. And the other quote which we got from the client was that these mothers say that there's a big difference between the services that they were accessing during the pre-COVID era and now, because this time they just spent a short time at the health facilities, unlike in the past when they could stay a longer time and get all the information that they needed. And another mother also told us that the painkillers which were supposed to be given to them after delivery to relieve their pain was not there. Mostly because the government, when there was this COVID-19, they directed most of their efforts towards COVID-19. Hence, these mothers were also just asked to go and buy their medicines to relieve their pain, and even when they want to be sutured in terms of delivery. So these are some of the quotes from the mothers. Thank you very much. And we feel that this research is very important. And if these recommendations can be followed, I think this is something that can also contribute to the reduction of maternal mortality, even as we continue fighting the COVID-19. Thank you very much.
Well, thank you very, very much, Brenda, for those insights. You know, COVID presented us with a situation that has never been seen before. And just from the data that you've shown us and, you know, the services having gone down and people being scared of going to health facilities to seek the medical attention they required, needs definitely a lot of intervention from the various ministries of health, working in collaboration with different partners, whether from the international development sectors or the private sector. And it's good to see even this quote from the people, the clients, the mothers who are receiving this care. Thank you so much for that, Brenda. Next up, we'll have evidence on the effects of COVID-19 pandemic on FGMC and child early and forced marriages, a case presented for Kenya, Uganda, Ethiopia, and Senegal. So I hand now over to Dr. Tony Kipsandui. Tony? Dr. Tony? Yes.
Yes, Liz and everybody, a very good afternoon from Uganda. I want to believe that my screen is on and can be viewed by everybody.
Absolutely, yes, we can.
Okay, thank you so much. Okay, so my name is Dr. Tony Kipsandui, as had been mentioned earlier. I am a staff of Amref Health Africa in Uganda, and I'll be presenting to you the effects of COVID-19 pandemic on FGMC, and that is female genital mutilation and cutting, and CEFM, which is child early and forced marriages. So the problem that we had at hand before this study was commissioned came from the fact that we all remember in February 2020, the World Health Organization announced a pandemic that is caused by COVID-19, and several countries, of course, put into place many containment measures, and notable among them was the lockdowns. So with these lockdowns in place and others, there were bound to be some issues to arise. And so shortly after this, containment measures were put in place and took effect. We began to see key issues emerging. One of them captured here on, should be on everyone's left-hand side of the screen, is a story that was captured by the Guardian newspaper. And it relayed a story of almost 3,000 girls from the Kuria community, this is in Kenya, who had undergone female genital mutilation in the recent weeks, that's in a few weeks, following the crackdown, despite the crackdown following the lockdown. And then on the right, you'll also notice that Al Jazeera captured a story as well that talked about classrooms closed and therefore worsening the FGM situation. Again, a case coming from Kenya. So with this in mind, there were also concerns coming up from various entities that, of course, have been having a lot of interest in FGMC and child, early, and forced marriages. Notable among them was the UN Joint Program. This is run by UNFP and UNICEF, and they actually sounded an alarm. And this is captured here, the impact of COVID-19 on ending FGMC could have far-reaching effects on the effort to end FGMC and CEFM. That came from the UN joint program. And then they went ahead to also develop models that predicted where we would be in 10 years' time if something is not done. Of course, we had to deal with the pandemic, but also the pandemic came, like we all know, with the disruptions to programming that has been ongoing. One of them is FGMC programming and other related violations of reproductive health rights. So it was noted that 2 million FGM cases could actually occur over the next decade if nothing was done. The second one was there would be an additional total of 13 million child marriages that would actually take place if nothing was done. And because these issues were coming and emerging strongly, we could not easily trace, empirical evidence that could speak to immediate revisiting of the programming, the interventions that needed to be done, so that the vulnerable group, the women, the girls, and the children, are actually protected during the pandemic. So that forms the basis for this study, and Amref, with support from the postcode lottery, from the UK and the Netherlands, through our offices in those countries, got funding, and we undertook this study. So I'll not take a lot of time on this slide, but just to quickly mention that the study was conducted in 4 countries, that is Kenya, Uganda, Ethiopia, and Senegal. And the aim was to generate evidence on the impact of COVID-19 pandemic on FGMC and CEFM to inform policy and programming in Africa and elsewhere. And those are the study objectives, 3 of them. And I'll not go to the details of the respondents, but just quickly to mention that we did household surveys looking at a population 15 to 49 years in the countries that I've mentioned, and then did in-depth interviews with program implementers and policymakers in those same countries. So these are the findings. In Kenya, the COVID-19 pandemic greatly or significantly contributed to the increase in both FGMC, and as you can see, it rose from 15% to 54%. That's significant. And for child, early, and forced marriages, there was equally an increase from 22% to 64% in terms of cases. So what we realize here is we already had a situation at hand that our programming was handling and trying to address. And then COVID came and interrupted this programming, and this explains what we found out. And this is attributed to closure of schools, economic losses on the side of the families and community, people staying at home, including potential victims of FGMC, among others. In Uganda, we found that there was a minimum increase for FGMC cases. That was noted 5 to 7%, but I'll say something about that. And there was a significant increase in child, early, and forced marriages. That rose from 14% to 69%. This was quite huge. Now, for the FGMC cases where we observed a small increase, It is important to note that the data collection happened before the season for FGMC in this part of Uganda. So that might explain this observation of small increase. The picture probably could be better if we had gone there during the season. In Ethiopia and Senegal, on the other hand, the COVID-19 pandemic seemed to have had a minimal effect on changes in FGMC and child and early and forced marriages. In fact, in Senegal, the CEFM stayed the same. So there was no difference before the pandemic and after. It remained at the rate of 13%. But we note that challenges continue to exist also in these countries on reporting FGMC and CEFM cases. So that might have been a limitation as well. And we also found that the efforts to end FGMC and CEFM have been negatively impacted by the COVID-19 pandemic on the whole. That's the conclusion that we make. And we know from the findings also that the pandemic negatively affected systems that were in place to address the FGMC and CEFM situation in these countries. Notable among them are the justice, the legal, and the health systems, among others. The civil society also had lots of programs that were interrupted. And so we say there is need for innovative approaches that can help in preventing FGMC and CEFM during a pandemic such as COVID-19. And this requires using alternative approaches to address them. So here is a list of policy, programmatic, and research recommendations coming out from this study. One is to develop economic empowerment initiatives and social safety net programs. You know, a pandemic of this kind throws people into a distortion situation where the normal safety nets are disrupted. And so this needs to be planned ahead of time. There is need to support informal online and mobile platforms to reach those at risk, the women, the girls, and the children. If that's not done before any containment measures such as lockdowns, and then they'll become even more vulnerable. They need to put in place measures to ensure that legal and judicial officers, healthcare workers, and the like continue to access those that they need to serve, the vulnerable women and the girls. There is also need to enhance outreach efforts to reach them with services. And we could do this using even the local champions where lockdowns were instituted and effected. We could use religious leaders and other community health workers. There is also need to strengthen relevant government ministries and agencies to enforce all instruments and guidelines that are put in place. And then there is need to integrate FGMC and CEFM programming into long-term pandemic preparedness plans. And last but not least, conduct research on gendered policy, on gendered implications of public health emergencies such as COVID-19 and effectiveness of alternative approaches. Thank you so much for listening to me.
Thank you very much, Dr. Tony, for those really amazing insights. I mean, we can all see based on your study, the grave impact of things to do with school closures because of the pandemic. We've seen how COVID-19 has impacted in terms of FGM, I mean, rising from 15 to 54% on FGM and 22 to 64% in terms of early and forced marriages is something of great concern. Thank you for those insights. I want to mention that we will be sharing links to these key studies at the tail end of this webinar. Please do keep your questions coming in on the Q&A segment. Up next is Dr. Tamari Eshel, who will be presenting on the role of community health workers in prevention and management of COVID-19 and its associated gender-based violence. Dr. Tamari, welcome.
Thank you, Liz. Hi, everyone. Yes, so my name is Dr. Tamari, like you've heard. I'll be discussing some of the findings around the role of community health workers in prevention and management of COVID-19 and its associated gender-based violence. So we all know that community health workers play a significant role within the health systems. I think my slide is not moving. Yeah. And they are a critical human resource for the prevention of COVID-19 and also forming that linkage between community and health facilities. We have about 2 million community health workers in Africa, but yet they are the unsung heroes, especially regarding their work around communities in terms of COVID-19 preparedness and also response, and also around the issues of gender-based violence. So some of the gaps that we sought to explore were that the role of community health workers is not very well understood, and also their role with regards to support to the health systems in COVID-19 and GBV response is also not very well understood. So we sought to generate evidence around their role in order to provide data to inform gender, to inform responsive and interventions and preparedness in the future. The study took place in Kenya, Uganda, and also Senegal. Some of the main findings that we found were that 1 in 3 respondents reported child early and forced marriage during COVID-19, and this was attributed to financial instability. 1 in 3 respondents in Uganda, 1 in 5 in Kenya, and 1 in 10 in Senegal reported intimate partner violence. A significant number of households survived on less than 100 USD in a month, and this was of course attributed to COVID-19 related job losses. And the main forms of violence that were reported were lack of communication, denial of basic needs, denial of finances, physical and verbal abuse, rape and sexual assault. And 1 in 3 respondents from Senegal and 1 in 10 in Uganda sought help from police and local authorities. And here we see that not many reported gender-based violence cases are actually reported forward either to the administrative authorities within the villages or also to the police. And then when it comes to some of the information that was provided around COVID-19 and gender-based violence, a lot of the communities had this via national TV and then local radio and then national radio. Again, here you can see the role of national radio stations that are speaking vernacular languages to the communities provided a lot of information around COVID-19 and gender-based violence. And then a lot of people actually had contact with community health workers during the duration of the study. In Kenya, you can see close to 75% reported having contact with CHW, and in Uganda, about 60% also had contact with a CHW. With regards to more findings, so the role of CHWs in COVID-19 and GBV prevention, the CHWs took part in the distribution of masks and sanitizers. They also reported suspected COVID-19 cases. They did contact tracing and even monitoring those that were in quarantine. They also conducted community sensitizations around COVID-19. They demonstrated hand washing and masking skills. And then they also formed a critical linkage between the community and the health systems. With regards to the management, so what did the community health workers do to manage COVID-19 and GBV during that period? They provided psychosocial care at the community level. They also provided home-based care of asymptomatic cases. They monitored patients who were in home-based care. They also referred cases, suspected cases, to health facilities. They identified people that had COVID-19 symptoms and supported them to go to the hospitals. And of course, also supported the reporting or the referral of gender-based violence cases to the administrative chief and also police structures. They also supported in burying of the COVID-19 victims. With regards to some of the challenges highlighted, they say that there was a lack of personal protective equipment. They lacked necessary training and skills to support their work within the community level. They also had hostile reception due to issues of COVID-19 stigma. And then they also lacked skills for provision of psychosocial support. They also lacked supervisory kind of service in terms of the people or the health system really looking after ensuring that CHWs undertake the services that they need to undertake within the community. And of course, there was also a lack of policy frameworks to support the CHWs within the health systems. And this provided a huge problem for the CHWs because there were also related issues around stipend and financial difficulties that they experienced to support them to provide their services. So on policy recommendations, our study recommends that we need to strengthen supervisory support to community health workers, including leveraging on technology. We also need to build capacity for the community health workers to support COVID-19 prevention and even provision of community care kind of support, including psychosocial support. We also need to strengthen collaboration and partnership and coordination between community members, community health workers, and also the overall health systems. We also need to strengthen funding and investments on community health workers' interventions. We need to develop tools and avail them for community health workers' use and using technology. And then also we need to strengthen or continue surveillance and response systems to gender-based violence and related COVID-19 impacts. Thank you for listening. Back to you, Liz.
Thank you so much, Dr. Tamari, for those insights. We can see very many interesting and diverse policy recommendations that your study gives. It also is very eye-opening to see the number of cases that were increasing in terms of gender-based violence. Thank you for that. Remember to please keep your questions coming in. We will answer them at the very tail end of this session. We have half an hour for all the questions that you may have, clarifications or additional information that you may require. Next up, we have Martin Moshangi, who will be presenting on the performance and utilization of hand washing stations deployed in response to COVID-19, a case study for Kenya. Over to you, Martin. Martin, I don't know whether you're on mute. Okay.
Yeah, sure. And I hope you can now hear me clearly.
Yes.
Okay, very well. So thank you so much, Elizabeth, and I'm here to advance the work which was begun by Eric Chandwick. Dr. Kivinji mentioned about him. And so I want to speak about a kind of a study which we did on performance and utilization of hand washing stations that were deployed during COVID-19 response in Kenya. So my name is Martin Moshangi. I'm the program director for WASH and NTDs at Amref Health Africa in Kenya. So moving forward, moving forward, I want to speak about the problem or what the challenge is. You realize that we all understand that hand washing is a proven prevention measure against most respiratory infections and intestinal infections. And you know, there are statistics which are already there. But the challenge here is that about 67% of Africans are the only ones who have been ratified to be doing proper hand washing, which means the rest are actually not observing hand washing. So what are the barriers? The barriers are like low investment in hand washing itself. It is the lack of information about why and how to wash the hands. It's all about raw hygiene or poor hygiene behavior, which is proliferated by social norms. And social norms is like what you value, what the community values, and what is promoted across the community. So what happened with COVID-19 is that there was mass installation of hand washing stations, especially in the public. So, but there's very little evidence, and especially when you are speaking about Kenya, on how the maintenance of these public hand washing stations was happening. So our study was basically to check out how the utilization is how the maintenance is, and how well the hand washing stations are being taken care of. And this is to answer the question around sustainability of the public hand washing stations post the COVID pandemic. And thinking through the systems approach that would definitively help us to maintain the hand washing stations beyond the pandemic. So we did a walkthrough study across 5 counties, and our objectives were simple. The first thing we wanted to check about functionality, accessibility, maintenance of these hand washing stations. We wanted to check about the barriers and the numbers to effective use of the hand washing stations. And we wanted to check about the sustainability gaps of these hand washing stations. So I'll speak about 4 key findings, and they are just basically around the functionality, utilization, maintenance, and a little bit of reflections around what the caretakers said about their experiences of these hand washing stations. So beginning with the functionality, I would want to say that about 74% of the hand washing stations that were installed were still present in the intended areas. That means that the movement or the vandalism was quite low to our own assessment, which is a good thing. It shows that people started appreciating the role of these hand washing stations. The second thing which I want to report is about that 83% or about 84% of these hand washing stations were functional 6 months post installation, which means all those which were accessed hand water, they were soap, and the tap was actually functional. And also want to say that with regard to utilization, about 85% of the users, the 85% of observed users washed their hands using soap at the time of observation. And it's good to say that about 3 users per hour were observed. Now, the other thing is like 15.8% or about 16% could not access the hand washing station. And this is either children, people with disability. And it presents a big question around how we are including everyone when we are trying to design these hand washing stations. Now, with regard to maintenance, I would want to report that about 80% of the caretakers were reported to visit the hand washing stations multiple times and ensure that water, soap is replenished. So this really tells us that now people started taking hand washing a little bit more seriously. If you look at the statistics which I presented about those people who wash their hands regularly, and what I'm trying to speak to here, you realize that our study finds that people are now taking hand washing a little bit more seriously. Now, from the qualitative perspective, what did the businesses say? That they would want to have an extended role in management of public hand washing stations. And so what this one means is that the government moved in and installed some of the hand washing stations. They were providing water and soap. But what the businesses would want to see is that an additional role is given to them, perhaps, or partnering directly with the government to receive the water which they normally share out for the purpose of replenishing the hand washing station. And they feel that by doing so, it will become more sustainable. The second thing, which was reported by the businesses, is that they would want some shared form of responsibility. And I'm speaking to the kiosks, the small shops, which are normally in either informal settlements or in the rural areas. They would want to see a shared role of managing a hand washing station. And they feel that if such kind of a system is organized, then cost can be lowered, and then access and sustainability of hand washing station can be more sure. Recommendations, I have 3 of them. First of all, looking at it from the management and oversight perspective, we believe that if local governments would adopt a framework of partnering with local businesses to promote, the private businesses to invest in public and washing stations, that will be a very good thing. So whatever is available right now is under the Public Health Act, but then that perhaps is not fully sufficient to drive an entire process change, whereby every business, everywhere, people appreciate that hand washing station within those premises is necessary. The second recommendation that I would want to put forward is around engaging the communities to understand the need for behavior change, especially in hand washing, and to create that social norm that ensures that people continuously wash their hands and observe hand hygiene. So the third thing I would want to speak to is the issue around operations and maintenance. If we can organize a system around the PPP model, which is already very clear about supplying the hand washing stations and how to run them, I think that will be a very important thing. So we end up our study by concluding that all what we need to do is to seriously invest in hand washing for all. And this is the only sure way of ensuring that we are able to get to the next better normal. So thank you so much. I want to stop at that and seriously appreciating the Rwandan School of Tropical Medicine and Hygiene, AMIU, the HBCC partnership, and the NBCC partnership. So thank you so much.
Great. Thank you so much, Martin, for those insights. I remember as a kid, we kept being told, wash your hands before eating, wash your hands when you come from outside. But over time, those never really came to play. But during the pandemic, we saw more and more people, even small children, getting into the habit of washing their hands frequently or sanitizing frequently. But it's also interesting, for us mentioning that we need to keep our hands clean, we need to sanitize, etc. It would be interesting to see what about those who don't have access to that running water to be able to wash their hands or be able to keep this hygiene behaviors on an upward trend. How about them? But thank you so much. I'm sure you'll answer those questions at the very tail end. Up next, we move to the next presentation on the equity in COVID-19 mitigation and policy response, a case study in Kenya and Uganda, presented by Dr. Shifra Kuria. Dr. Shifra?
Thank you very much, Liz. Good afternoon, everyone. And like you've been told, I am Dr. Shifra Kuria, working at the regional office in Amref. And we continue to look at issues related to COVID. And let me say from the very onset that we did this research in collaboration with University of Southern California, who are our partners. And we were funded by the government of Netherlands through the Include platform, and we acknowledge them for that. So we have had about COVID-19, I'll not repeat, just to say that it is a continuing challenge. As we speak, we know that Kenya just came out of the third wave, and Uganda experienced a wave that is just gone down. And just to remind ourselves that even before this pandemic came, there were glaring inequalities, whether you think of income and also access to the critical services. And we are thinking of health, but also beyond health, because these other issues are very important. They are the social determinants of health. And for this research, I will concentrate more on the other things because so far we've had quite a bit about health. So when the pandemic came, different measures like we have had were put in place. But the challenge measures, of course, plus the pandemic itself, they did disrupt lives, and they actually still continue to do so, thus threatening the many gains that have been made over the years in the health sector, but also in other sectors, including trying to bring equity in the different areas of life. So we explored how these policies affected the lives of people, with particular attention to human rights and equity. So we'll mainly be talking about equity. And we did this in Uganda and Kenya, and mainly by studying a lot of literature, looking at what media had reported, but we also interviewed some key informants just to get the full picture. And coming to the key findings, number one, I would like to reiterate that the governments of both countries did a lot to control the pandemic, which is commendable, because nobody knew how bad this pandemic would be. And actually, it's like it was being thought that it could be as bad as the Ebola, which doesn't give time. So both Uganda and Kenyan governments put in various measures, but unfortunately, what we have seen through this study is that the most vulnerable, those of low economic social status, are the ones who are affected more negatively by these measures, and of course also by the pandemic. And besides putting in the measures like lockdown, which we've already heard about from the other presenters, the governments also went ahead and put in different safety nets. But what we have seen is that even those measures they put in place to protect the vulnerable, they did not reach the most vulnerable in many cases. And when we talk of the vulnerable, we are thinking of those living with disability, like Martin has pointed out to some how some interventions did not reach them. We are talking about those in informal work and businesses. We are talking about those who live from hand to mouth, those who are disadvantaged in terms of reaching different resources and services. But besides that, the other thing that we found out that we would like to highlight is how many local innovations were brought in at that time, which shows that actually both Kenya and Uganda, we have a lot of potential. It just needs to be nurtured. Now, I'll just concentrate on a few measures and the effects they had, just to highlight how inequities were exacerbated in this study or during the control of this pandemic. We have heard about lockdown. Both countries had daily curfews. They restricted individual movements. And at the beginning, around April, May, both countries prohibited all public gatherings. And they also, for some time, prohibited movements, whether by rail, whether by public means. And in Uganda, at some point, even by private cars, because there was a total lockdown. And also there was closure and restriction of operating times of different businesses, like, restaurants and all that. So what did and many other measures, these are just the ones I decided to highlight. So what how did they affect? Sorry, I don't know why that, okay, sorry, there we are. So how did they affect equity? We see that the very vulnerable people are the ones who could not reach services, and not just health. Think of justice. And this is the time when things like some problems like gender-based violence, issues of FGM, like you have heard, they had increased, and even our study shows that in both countries. But there was no way of getting to the justice system. Then there was mass unemployment, loss of income, increase in dependency. And you know, for health, what this means is that it automatically affects health. Not only don't people have the resources to go to the health facilities, but also just by merely not being able to have the resources to wash their hands, to eat well. Yeah, that was a major challenge. Some people even changed their dietary habits. The other thing is that we know schools were closed, and we know that also because of the isolation and economic anxiety, there were many health crises, whether for health workers, but also for the general public. Finally, just an example of social safety nets that were put in place, but they did not, and how they did not reach the people they were intended to. So we had economic stimuli and tax relief in both countries. We also had food relief in informal settlements and cash transfers for the elderly. And we had the use of technology to try and give some of these services after some time. Now, the limitations for this is that they did not reach the most vulnerable. Why? Not because that was the wish of the government, but because there was inadequate identification of those who are vulnerable and the system of reaching them. For example, in Uganda, there were rules outlined on how to apply for this, the package for businesses. But it was such that the informal people were not able to really get it, even when they formed groups as they were advised. So the marginalized were left out also when the services were shifted to technology, because either they had no internet, they had no gadgets, so inequity was further exacerbated. So what recommendations do we give? One, we would want to ask the governments of both countries that as they are putting in place the social safety nets, because the measures still keep on coming back there and then depending on the waves, they need to have adequate characterization of the vulnerable. It is not just the elderly, but even if it's the elderly, from what age? And they need a database to be sure who is this who is vulnerable, especially for those who are falling back. Some people had jobs, but with the massive loss of businesses, they have now fallen back to poverty. How does the government capture that? Very important. The other thing is the national and subnational governments to continue decentralizing services, and not just health, because health we've been campaigning. What about the courts, or the high courts, so that even when people are not able to move, they can still access services? And the other thing is to continue digitalizing the services so that whether there is a crisis or not, then the services are more available. And this is doable, like we have seen, but only we make sure that we are not leaving out some. Then the third recommendation is that the government and other stakeholders must make available accessible free helplines for services, especially counseling, because of mental health issues, but even other things, you know, the gender-based violence, for child protection, the justice system, so that even the poor, this should not just be for those who are well educated and all that. And through communities, this can be done. Maybe work with community health workers and such other networks. And finally, the line ministries should support the local talents and innovations, because we saw that there is a lot that can be done. And this will not only enhance the response, but will also help in economic growth. And so this support should focus particularly on those who are in formal trade and businesses, the women and the youth. not to discriminate, but because the study has shown that these were the most affected and they suffered most. So if we are to have equity, then they need to be prioritized. Thank you very much. I'll stop there. Back to you, Liz.
Thank you so much, Dr. Shifra, for those insights. You know, they say necessity is the mother of all inventions. And for me, what is noteworthy from your presentation and your research is that during the pandemic, we saw both in Kenya and Uganda, a lot of local innovations to mitigate effects of the pandemic. So that's quite something really encouraging, but also the policy recommendations that you make to ensure that equity applies to all are taken into consideration. Next up, last but definitely, as I mentioned, not the least, is some closing remarks by Dr. Jessica Nsungwa, Commissioner, Department of Reproductive and Child Health at the Ministry of Health in Uganda on the role of research and development in informing government policies. Dr. Jessica, over to you. Thank you. Sorry, you're on mute.
Thank you very much and good afternoon, everybody. I think it's a pleasure for me to be part of this dissemination, and I want to thank all the panelists. Today, I'm here to give my perspective and about research funding and how we use research for policy making. Before I give a specific answer, I want actually to reiterate that the current crisis, based on the studies which have been presented, has inflicted devastating health and economic costs to most of our country. And I think this has also created a once-in-a-generation chance for structural and health system change or improvement. It has been able to expose underlying system weaknesses in many countries. And for us to drive the gains we are targeting the 21st century, I think countries will need to reach new levels of performance. We need to recommit ourselves that we are going to provide health security, that we are going to provide stability and prosperity, I think, for our people. And I think this pandemic has really put doubt on many people's life, whether they have any long-term prospects. So research and evidence is one of the tools we have to be able to make optimal decisions that are not only compelling, but also can help us to advocate for more resources based on facts. In countries, we need to make decisions. And as we make decisions, we have several questions. We have many questions. Decision makers have questions on what can save lives. How can we save money? You know, how can we make our health systems work better? How can we power them, you know, after the COVID? How are we going to take off? So there are many questions. There are also very many questions because of the new things that have emerged. There are things to do with the vaccines being manufactured in a laboratory science, which has not been well familiar. There are issues about the variants. We don't have evidence and data. There are issues to do with the infrastructures, which can be sustained. Treatments in Uganda, we have both medical and local, or Western and local medicine, and they are both competing with each other and don't have evidence. And yet we have to make decisions. We have recently moved to promoting home-based care. We don't have evidence. So the question is, how are countries, what's my experience in countries funding research as one of the inputs to improve decision-making? I want to really start by saying that generally there's been a big data reform, information reform, both globally and locally. I think increasingly we are seeing people think about research, think about data, and also fund data. The biggest gap we have in terms of information and data is actually funding research. There's funding for routine information, there's funding for periodic surveys, but for research, which is generating evidence, for implementation, we have a problem. And there are many factors, and I want to begin with the simplest one, the issue of availability. Many of the policymakers don't have data, this data, it's not available to them. And because it's not available to them, they can't even advocate for it. Many of them are not even aware that there's existing information or information in the pipeline. But also many of them cannot access it because either it's in electronic form. People actually learn more from the evidence in the newspapers than research. Policy briefs may be produced, but sometimes they're also not very informative. And I want to say that with the coming of infographics and scorecards, it's becoming more easier for us to appreciate and access research, and therefore promote it and be able to negotiate with our policymakers for funding for this research. The other requirement which has been a problem is the relevance. Most of the researchers, when they start this research, they don't engage the people who are going to be using this research. Stakeholders who will be affected by the findings, by the recommendations, are not usually involved. Therefore, they're not intimately familiar with these findings. They can't present them, they can't use them to judge what's going to happen, and even advocate for them. So this is a very great weakness. And because of that, you find that funders are not prioritizing research. Governments in particular are not prioritizing research. The other biggest problem we have is also that the usefulness and the timing of the release of the research. Today, if you produce some research on some issues in COVID, you're more likely to get funding and support as opposed to doing research maybe on nutrition, for that matter. So the timing. So we have an issue of the mismatch between research and the users of the research. And I think this is well known and published. But in Uganda, for example, we have been seeing incrementally government putting money in research. And I want to thank the partners. Our partners have been very central in supporting also research, like the World Bank. The World Bank currently is supporting research, not only research like applied research, but implementation research. And I want to tell you, implementation research is the research we need most. It's a kind of research which helps us to think about why are things not working. We have the technology, we have the instruments. Why is it scaled up? Why are innovations not being expanded? And that kind of research is not very popular among the researchers because you have to be embedded in the system to be able to know the decisions, the questions the government is asking. And when we ask such questions, we find it very easy to find funding from government, because then government starts relating with this information, especially since it's ongoing, and they're using it to develop plans, they're using it to develop global fund plans, they're also using it to negotiate for money from Ministry of Finance. So implementation research has been one of the other areas which have helped us, especially if the researchers are familiar with the Ministry of Health work. They either attend our reviews or they attend our planning meetings and have understood our particular dimension. That has been made it very, very important. As I said earlier on, some funders are also giving us money and they have nested in the work they're doing some research. And this research has made it very easy for us to be able to work alongside. We do implementation and then we do research alongside to be able to do this. But also I want to say that one of the other things which have made us start thinking about research are the global indicators. A number of the global indicators are actually qualitative. Issues to do with satisfaction are becoming more important. Issues to do with research and equity are becoming more important. And governments are being compelled to put money in these areas because we can't just pick them from routine data. We can't observe them because we can't be on the ground all the time. So that area also now is stimulating money for research. In Uganda, we didn't even have a research unit until about 3 years. They've just established a research M&E and research desk in the Ministry of Health. And that's surprising, but it has been existing. And many times we've been relying on university research, but because we don't align with each other, most of the research is not taken on. I want also to talk about something to do after you have disseminated. And suppose this research is presentable in a way to understand it, it's timely, will policymakers use this research? The answer is not always correct. I saw Tony's slide at the beginning. It said that generating evidence around the impact of COVID will provide data to inform response interventions. I forget the last one. So that's a big assumption Tony was making. And that is what we want. But it's not necessarily true because even when we get these recommendations, we may need support to reinterpret, to unpack these recommendations. They are very good recommendations to make, but the researchers need to continue negotiating after disseminating and being part of the process so that we as policymakers find it easier and you enable us to be able to take up this research. So what you do after the dissemination is also very, very important. And finally, how do you generate the questions? Where do you pick the questions? Many researchers are doing research based on the funding. Their research topics are guided by the funder. And yet we have very many research questions. Our research questions range from small questions to big questions, to very deep questions, which are very complex. So researchers also need to put their ears on the ground, because those are the kind of researches which can attract funding. I want to talk about also the area of South to North partnership. Because we have signed MOUs, government has also been able to co-fund these researches, but also host fellows, research fellows in the Ministry of Health. And that way, government has been able to put some money in research. So today's findings are very important, and I hope that we as a group working with Amref will be able to package this research for policymakers and be able to help policymakers advocate for these recommendations. But not only that, I hope that there will be a process to follow up policymakers to see how they are navigating these recommendations and being able to adapt them. And we need to be flexible. Some of these recommendations are not based on very important, relevant facts of the Ministry of Health. And when you disseminate, people say, oh no, this is happening. And as a researcher, you may not have come across. So we need to have some flexibility to be able to extend this work, to expand it, and make sure that it's suitable for policymakers. I want to stop there, and I want to thank you very much.
Fantastic. Thank you so much, Dr. Jessica Nsugwa, for that amazing insight. I think you were very spot on when you said, you know, sometimes people get to consume a lot of these policies and research on the newspapers, on infographics. When this information is made palatable and broken down to people to be able to understand, then we're able to move the needle in terms of the research and development work that we are doing. And that was really spot on, being one of the key reasons we're having this session today, our media webinar, to really break this down into, you know, things that people are able to understand and to be able to be consumed by the public at large. Thank you so much for your continued support for research and development in Uganda and in the broader African continent. We really do appreciate that, and for your time today. Thank you to all the panelists for all your insights into the various studies. We're now in the session of the Q&A, and we have quite a number of questions that have come in. And I'll take the first two that are going to Professor Joachim Osur. And one is from Martha Claire Kerubo, who says, I learned from somewhere that vaccine needs to be accepted by medical personnel and people involved in it first before other citizens do, because they will only be convinced to get vaccinated if someone on the front lines does so. So there's need to sensitize medical care personnel and those in the health line to fully understand the importance of vaccinations for information to trickle down to the community. Perhaps please share, Professor Osur, some of the key initiatives that Amref has been doing to ensure that the frontline workers are leading from the front, ensuring that we are averting issues of vaccine hesitancy. And speaking of vaccine hesitancy, another question to you, Prof. Osur, is, are there any studies linking vaccine hesitancy to fertility? Prof. Osur?
Yeah, thank you. Thank you. Yeah, so a lot of work is being done to reduce vaccine hesitancy, and Amref is involved in a number of the initiatives. As I said, we now know why people are hesitating. They're lacking information. They don't trust even the government. Their source of information is not one that can be trusted, and so they are getting a lot of anti-vax messages. And so what we are doing on our end is to work with the ministries of health to put the right information in the right channels to reach these people. We are also working very closely with community health workers, training them, giving them capacity to respond to what the communities are worried about. And as I've said, if we can have community health workers on our side, if they can have all the answers to the questions communities are asking, then most likely they will be able to mobilize communities to accept the vaccine. And so Amref is very strong on working with community health workers as part of the health system. We have a training for them, which is formalized, and we are doing mass training through a virtual platform we call LEAP, and this is in many countries now. We continue to, because the information keeps changing, we are getting more information all the time. So we continue to advance that platform to put in more current information so that the community health workers we're working with are very current on what's going on. In addition to that, we have a training for higher level health workers, nurses, doctors, and so on, just so that they also have the right information. Remember, hesitancy is actually there also among doctors and nurses and other higher level health workers. So we have a training for them as well. The other question was about fertility. From what we know scientifically, COVID vaccine does not cause infertility. In fact, if I give you some of the things that communities are saying, we've had in some places that COVID vaccine increases libido. In other places, we've had people say it reduces libido and causes erection problems. We've had in other places that it causes menstruation problems and infertility. All this is not true. The truth is that COVID vaccine does not affect sexual function or conception or pregnancy, future pregnancies. So that is what we know scientifically.
Okay, thank you so much, Prof. Osur, for those insights. We are seeing another question here from Dominic Kirui. Is it possible to send us links or PDF formats of this report via email, please? Yes, indeed. All the links to the press releases of all the studies that have been presented today, I've shared that on the chat function, and also will be shared with each and every individual that registered for this webinar session. So please check the chat and you will see policy briefs as well for all the studies that we have presented today. Alex Wamatuba is asking, what was the ethical consideration on the study which targeted FGMC and CEFM, since some of these activities are usually done in secrecy? Dr. Tamari, you want to take that question?
Thanks, Liz, and thank you, Alex, for your good question. Yes, so ethical considerations are actually really key, especially when we are conducting research, because we don't want to put our respondents, our women and girls at risk. And so if I understand the question correctly, the respondents, the questions that were asked to the respondents, they spoke about their perception with regards to the increasing cases of FGMC and child early and forced marriages during the COVID-19 pandemic. So it was not the actual cases that we recorded, but rather the perception with regards to the increase in cases before COVID-19 and also during COVID-19. Thank you.
All right, thank you, Dr. Tamari, for that. We have Teresa Minor who asks, how would we best utilize existing healthcare workers like community health nurses who possess skills and capacity to provide care using primary healthcare PHC, but deployed for curative services? Dr. Shifra, you want to take that question? Dr. Shifra, you're on mute. I think we lost Dr. Shifra. Dr. Jessica, would you like to take that?
I am back.
Okay, there you are.
Sorry, but I did not hear the question. I had some interruption.
No worries. The question was, how would we best utilize existing healthcare workers like community health nurses who possess skills and capacity to provide care using PHC, which is primary healthcare, but deployed for curative services?
Please repeat the question again. How would we
best utilize existing healthcare workers who possess skills and capacity to provide care using primary healthcare, but are deployed for curative services?
Oh, thank you. That's a good question. And it's on how we use our human resources. And without going into a lot of details, what I would say is that what we need to do is to rationalize the existing health workers, because they are few. We need to have equity, like we have said, and we should not be thinking only on curative services. All the other aspects, especially prevention, health promotion, and all that goes with primary health care is very critical. So I would say that it is important for the ministries of health to rationalize existing health workers and make sure that they are where they are needed most and where they give the most.
All right, thank you so much, Dr. Shifra. These two next questions are for you, Martin. And there's one from Alice Lakati. She says the high utilization of hand washing facilities is of significant importance. Do we have a follow-up study on the impact of this on hygiene-related diseases in the same counties as per your study? And number two, from Thomas Bure. My name is Thomas Bure, a journalist from Habari Kibra Media Platform. I have a question for Martin Moshangi on hand washing. How can we as storytellers help change community attitudes towards hand washing? During the pandemic, several NGOs each came with hand washing stations at key points where there was traffic of people. Over time, the stations have shrunk and only a handful can be seen. But even with a few points remaining, hand washing practices is not fully being embraced like last year. What can be done? Martin?
Yeah, so thank you so much, Liz. And I would want to say that it would be great to follow through with Dr. Akati and see whether we can actually undertake a study that can speak to the impacts of hand washing in the control of diseases, and perhaps take a specific disease, follow it through, and check out what we can speak to in a local context. So that one, I think we are going to follow through and see whether we can construct another study. Then to Bwire, Bwire, I've shared my contacts. It will be so nice to tell the story and encourage communities to start changing their behaviors and their social norms. So it will be so interesting to walk this journey together with you. I look forward to connecting. Thank you.
Thank you. Thank you so much, Martin, for those answers. We have one from, just one quick one, from Malcolm Gogo, who asks, how is Amref contributing to youth who are graduating from medical institutions and would like to participate or contribute to policy making of COVID-19 during these early stages as the studies are going on? We are delighted to have our Vice Chancellor for Amref International University today, Prof. Joachim Osur, who also presented on a study around youth and CHWs and vaccine hesitancy. So I will pose that question to him. Prof. Osur?
Thank you. So Amref offers a number of opportunities for young people to be involved. Our belief is that the future and even the now lies with the youth. Remember, the youth are the majority in our continent. We are talking of 60%, sometimes more. And so if the youth act, there will be change, whether it is in policy, whether it is in promoting hygiene practices, whether it is in health communication, the change really lies with young people. Remember, one of the studies I've presented was on the youth and what the youth think about the vaccine. And it worries us that up to 58% are hesitant. That means vaccination in Africa may actually not succeed until something is done about the youth. But now to the opportunities. One is Amref offers opportunities for attachment, internship, so that young people are part of the programs we implement. Internally, we have a very strong youth voice at all levels. Our staff, we have a number of staff who are youth. We have a youth movement across Africa. We call it Youth for UHC, Youth for Universal Health Coverage, which people can be part of. And these are youth who want to see change in health in Africa. They want to be involved in policy, and they're influencing at various levels in their countries, at community level, and even continent-wide. So that is there. But we also welcome you to be part of Amref International University. We definitely do have many relevant courses for young people to be involved, and also to share their experiences with other young people.
All right. Thank you so much, Prof. There's a follow-up question around, there is so much misinformation about the vaccines that are being propagated by social media that is leading to vaccine hesitancy. Just before Prof gives an overview on that or response to that, I'd like to mention that since the onset of the pandemic in March 2020, we set up the Amref Africa COVID-19 Information Center, which now hosts a lot of information, frequently asked questions, demystifying various things around vaccines and also around COVID-19. If you can, please access it through the Amref website. We've also partnered with Twitter, which is a tech giant and one of the places where a lot of this misinformation has been perpetuated. And what we've done with Twitter is we've partnered together to have various courses that support journalists from across the continent in ensuring that they're getting their skills enhanced in terms of how to identify fake news and how to really upgrade the ethical standards on how to report around emergencies, and not just this pandemic, but other health emergencies. So when you have a minute, please go to our newsroom as well as the Amref Africa COVID-19 Information Center. So part of the question is, how are we ensuring that this misinformation does not lead to a lot of vaccine hesitancy? Prof, as your study was on vaccine hesitancy?
Yes. So the thing really is a conversation with communities. There is really great need for ongoing conversation with communities, and each community is different. And that is why one of the recommendations in the study is that we need to put funds into community engagement. Right now, because we are all worried about vaccine, we don't have enough doses. A lot of focus is on that, but there is a missing link because the conversations at community level are really minimal. People are not getting their questions answered. And so the need to really have more intense discussions at community level to answer questions, to debunk myths, is very important in this process if we are going to succeed in vaccinating a critical mass of people.
Okay, thank you very much, Prof, for that. There's one input here from Rebecca Cherop, who says, my name is Rebecca, a public health scholar, and I have no question at all, but I'm here to thank all the panelists for such an insightful, educative, and eye-opening presentations on what exactly is happening on ground and how best we can work until something is done and achieved. Thank you so much, Amref, for organizing this. Thank you so much for that. This question is to Dr. Githinji Gitahi. And Martha Claire says, anyone who has contracted COVID-19 vaccine and recovered develops a certain amount of immunity against the disease than one who has not had previous infection of the same. Can we assess and say that one who has been infected before can be given only one dosage of the vaccine, while those who have not been infected can get the two, because the first dosage is clearly very important? Dr. Gethenji, please take that question. Dr. Gethenji, you're on mute. All right, as we wait for Dr. Gethenji, perhaps Dr. Jessica Nsungwa can take the question. Dr. Jessica?
Can you come again?
Yes, sure. So the question is, anyone who has contracted COVID-19 vaccine and recovered develops a certain amount of immunity against the disease than one who has not had previous infection of the same. Can we assess and say that one who has been infected before can be given only one dosage of the vaccine, while those who have not been infected can get two, because the first dosage is clearly important?
Okay, thank you very much. When you get COVID, definitely your body reacts accordingly, and you get some immune antibodies, IgM, and so on, which actually act in the same way like the vaccine. The only problem with the immune response is that it's not standard. We cannot standardize and assure everybody that every person will react in the same way. Neither can we say that the immunity is comparable with the vaccine. So since we don't have that information, we go ahead and vaccinate you again and assume that the immunity you had was good enough, but we need to make sure that we boost you, and then you continue the second dose. So you have to get the two doses even then.
Thank you so Thank you so much for that, Dr. Jessica. And perhaps this is for yourself or Dr. Gethenji. An anonymous attendee says, we should insist that vaccine coverage needs to be high to reduce transmission and emergence of new COVID-19 strains, and the first dosage does a good job with this. As the MOH said the other day, the longer we are waiting the time between the first and second dosage, the better the immunity. Could we as a community advise that the government should consider giving a higher population a first dosage before running for the second one first, when only a minute number will be fully vaccinated? Do you think it is important for a higher population to get the first vaccine first?
Okay. This has been an issue, a decision for countries. This has been a question on the table for a number of countries, whether they should go for having a smaller population, but with two doses, especially the most vulnerable, or rather expand and have a higher coverage for a single vaccine. I think the evidence which we have now is that a single vaccine is good enough. So if you can have as many people as possible receive the first vaccine, I think that would be very useful for the population. When you vaccinate people, whereas infection may not go down, you have people with less severe disease, and therefore you're able to work on only a few and the resources, and then we can intensify the preventive measures. So in Uganda, for example, that is the approach we are taking now. Initially, we went for the other option, but now we have decided, let's get as many people on board, and we are targeting 22 million people to be vaccinated.
Wow, 22 million people, that's amazing. Thank you so much, Dr. Jessica, for that contribution. We'll also hear from Dr. Gethenji on the same. And the question was, do you think a higher population getting a first dosage is important than only a few getting to bother with the first and the second, because only a very small population is protected. If our goal is to protect 70 to 80% of the population, shouldn't we then just focus on the first dosage? Any comments on that?
Yes, Liz, and I think I've heard what Jessica said, and I think that's a good decision. Kenya also had a similar issue when we got the first 1.2 million doses of AstraZeneca, and we decided the better thing to do is to actually go for as many people as possible in the first dose before you give the second dose to new cohort or new group of people. But then we actually got into a problem, because when we exhausted all the doses for the first dose, now there was demand for the second dose, and there was scarcity because there was no sure, consistent supply, for the second dose. So I think my advice would be that if you're going to go for that strategy of one dose, then you need to be sure that you have a source for the second dose. That's important, because we have seen, especially with the Delta variant, that though the first dose has a certain level of protection, it is not optimal. And we have seen more people in Europe getting admitted with a single dose than with a second dose. So we know that it is useful, but suboptimal. So the point then to make is, this is a strategy during scarcity. It's a strategy during scarcity. Now, if in the absence of scarcity, in the next 2-3 months, we expect we are going to have a flood of vaccines, in which case let's focus on the regimen of 2 doses where required and 1 dose where required, like in Johnson & Johnson. So the strategy of 1 for everyone was more when we did not have supplies. Now the supplies are going to be in excess.
Okay, thank you so much. And maybe our final question to you, Dr. Githinji, on from Razia Kwalentai Mwanga. I hope I pronounced your name and did not butcher it. Is there any research on the efficiency and effectiveness of the different vaccines to help African countries select the best vaccine? And number 2, is there research of vaccine used in Africa and East Africa, especially Kenya, which started vaccines early on, efficiency of vaccines?
Well, the issue of effectiveness of vaccine is a complex one. Because the first thing you need to note is that vaccines, when you're talking about efficacy, 70% efficacy, or you're talking about 90% efficacy, you're talking about aggregate of the 3: mild, moderate, or severe disease. But if you just isolate and look at efficacy against severe disease, which is what we really want to protect people against severe disease that requires hospitalization, all of them
I'm sorry, we can't hear Githinji very properly.
Apply at 100% against severe disease. That's what we need. Can you hear me now?
Yeah, but we keep losing you a little bit.
Sorry, I think the point I was trying to make is that we need to remember that all these figures of 60, 70, 80, 90 are when you look at the aggregate effectiveness of the vaccine from proceeding to mild or moderate disease or severe. But if you focus on what really matters, progression to severe disease, which is really what we want to avoid. We want to avoid people getting admitted. Then all the vaccines that we have, AstraZeneca, J&J, Moderna, Pfizer, 100% protect against severe disease, which is what matters. So we must remember that the statistics should not blind us from the fact that the vaccines are effective against severe disease and hospitalization, including against the new Delta variant. That's what we need to focus on. Studies in Kenya, in other countries, people are looking now at what is the rate of hospitalization for vaccinated individuals. And we know now that the rate of hospitalization for vaccinated individuals is very low. But does the rate of getting infected reduce after vaccines? We know that people get infected, they get mild disease, but they don't proceed severe disease. And that's really what you want. You know, mild disease is mild disease, but you don't want severe disease, which is why we vaccinate. So I hope that kind of gives a picture on that question, Liz. Thank you.
All right. Yes, it does. Thank you so much, Dr. Githinji, for that input. We've come to the very end of our media webinar on the various COVID-19 studies that we have undertaken. I want to thank each and every one of you for committing your time, 2 hours, being here. Thank you so much. And we're still a huge number, 87, from the very highest where we were at around 112 people. So thank you so much for being here, for listening, for trying to understand and acknowledge all the different insights that are being shared. As I mentioned, all the links to the various studies of the research that has been presented today, I have shared that on the chat. The policy briefs I've also shared on the chat. If you'd like to go take a look, please go to our newsroom.amref.org, newsroom.amref.org, but we will also share all these policy briefs, the links to all the research studies to each and every person who had registered for this webinar. Thank you once again for coming in. Thank you to our IT. Thank you to our panelists. Thank you to our translators for being here. I want to thank each one of you for creating time to be here with us today. Until the next edition of the media webinar, it's goodbye from us. Thank you so much.